Let me see. This is start the recording. Okay, yeah, yeah. All right, just a minute. Okay, it's starting up recording now. All right, um, so that's what the problem with med 3 and med 3 and med 4 record, especially for the pathology is concerned. Okay, so whenever you see the best way is like as it comes out, you just memorize it. Try to picture where the fried egg is, that kind of things. So, but still they use the that terminologies like buzzword, and sometimes they are still in the questions. So you have to be familiar with those kind of the terminologies. Okay, so it's just being naive and then being honest that, oh, I don't see any fried egg, doesn't really help you. Okay, so whenever the only possibility is that you have to you have to like you have to try to understand, find where the fried egg is, which uh, part is the white part, which part is the yellow part, and or if they say the palisading, that kind rosette thing, that kind of things, then you have to figure out, oh yeah, that there's like the leaves of the rosette, and so this will look like rosette, that kind of things. Okay, so that's the reality, right? So you have to expect that. Okay, I just wanna just go through the first few pages is just to show you the pictures of the what you need to know in terms of the neurologies. Okay, spinal cord and the brain stems. Okay, so this is just the brainstem, I mean just a spinal cord, the diagram. Okay, so all you need to know here is not because of the metry, it's not, it's really kind of more focused on the pathology than the the anatomy. Okay, so physiology is a big thing always, but the anatomy is kind of less emphasized. But I'm giving you the caveat, very, very important thing. It doesn't mean that the neuroanatomy is not important. Just simply that because you learned neuroanatomy in Med 1, so that's why they don't emphasize particularly for the neuroanatomy. But neuroanatomy is a very, very high topic. Okay, so make sure that you know that. Okay, so unlike other types, other anatomy, neuroanatomy is very, very important thing, because there's even neuroanatomy book, and then there's a neuroanatomy class. Okay, so that means there's no such thing as like GI anatomy class. There's no such thing. Okay, but in neuroanatomy is so important. Then there's a neuroanatomy book and then neuroanatomy class. Okay, even some schools have a neuroanatomy major too. Okay, very, very important. All right, so if I just highlight the very high terms, then you just this, as you go here in the center of the dorsal column, you sacral to lumbar to thoracic, it's kind of going up. Okay, all right, going down here. Okay, and then the same thing in here. Okay, same thing in the lateral coracospinal tract. It's kind of sacral is kind of the sacral is like more on the lateral side, and then going up in the center is a cervical. Okay, so it's kind of it's in some sense kind of opposite to this one. Okay, so that's something you need to know. All right. Then so basically lateral coracospinal tract, and then there's a anterior coracospinal tract, and also there's the anterior lateral system. That's basically pain and temperature. And here, lateral spinal thalamic trunk, anterior spinal thalamic trunk, right? The difference between, they are basically doing the same thing. One of the, like, in terms of sensation, in terms of functionality, they are usually same thing. Okay, but the one probably kind of little too detailed, but this one, no pain, but this one is a pain, and the instead of pain, it's like a crude touch, and temperature. And then here is a pain and temperature. Okay, so that's a little subtle different. Okay, so but you still have to know both. Okay, and then there's a vestibular spinal tract, olivo, the spinal tract, whatever. That's not very the important. But you need to know the dorsal column, obviously, and gracial and cuneatus. There's like more kind of side is the cuneate, and then the glacial is kind of central. Okay, all right. So you know all this one. I'm just reiterating what you need to know. Okay, and then this one I will come back this one, but make sure that you know you have to know this concept. But I will come back it. Okay. Rule of four. Rule of four is a very useful tool to solve the questions. This is like this has been in this the neurology field for a long time, but it's the not very well emphasized, but this is a really useful tool. If you know this, if you understand this, then you have a very big advantage solving questions. Okay, so basically it's kind of simple. So 3, 4, 6, 12, which is divisible by 12, meaning that for instance 5 is not divisible by 12, like 2 is divisible by 12, but 1 and 2 is kind of 1 and 2 is a kind of exception, because it's not really it doesn't really follow the rule of 2. It's just kind of separate 1 and 2. Okay, cranial number 1 and 2 is kind of separate. Okay, so that's why it's not included in here, although it's divisible by 12. So 3 is divisible by 12, right? And then 4 is divisible by 12. And then 6, but no 5, no 7, no 8, no 9, no 10, no 11. Okay? And then 12 is, of course, divisible by 12. Okay? So those are in the midline. So cranial 3, 4, 6, 12 in the midline. Right? And then everything else in the lateral part. Okay? If it's in the midline, then everything will start with M, motor functions. So motor nucleus, and then motor pathway, the MLF, and then medial lemniscus, meaning this is a dorsal column. Okay? And then if it's in the lateral side, then everything starts with S, sympathetic, spinal thalamic, so it's a pain and temperature, and then sensory nerve 5, and then the spinal cerebellar. Okay, so you need to know these two things. All right. Here, you need to know motor, and then medial lemniscus, and then MLF. Okay, those three things you need to know. All right. So this will be very useful tool when you have especially when you have the brainstem regions like midbrain, pons, and medulla, right? So this is like 1 through 4, 5 through 8, 9 through 12. Okay, so when you have the when you have a region in the medulla, then you have something you don't see anything with like the 1 through 4 or 5 through 9. For instance, medulla. If you have a region in the medulla, you don't see anything with the like eyes. Okay, eyes, like eye movement, that kind of thing. It's not in there. It's not in the medulla. Okay, and then for instance, if the region is in the midbrain, you don't see something to do with the like vagus nerve or something to do with the like the hypoglossal nerve, that kind of things. So no tongue movement difficulties and that kind of things. That's all in the medulla. I mean the medulla part. Okay, so but how do you distinguish whether it's like the 12 or 9, 10, 11 is due to the like this the rule of 4. Okay, so also rule of 4 will rule out. I mean rule of 4 will kind of separate the medulla, whether it's medulla or pons and midbrain. Okay, so this understanding this, overemphasizing this is not enough. You will have to kind of look this over and over, if you don't understand this, and then look for the some videos like YouTube videos like the body and beyond is good. Also, there are many YouTube videos that the explain about the rule of four. Okay, so uh, make sure that you understand that. This one, uh, before we this, I think this page is good. Right here. Any, this one is important, so I mark down in here. Any, the sensory, three neuron, motor, two neuron. Okay, so sensory, and also the second neuron. Oh no, sorry, it's not this one. In the sensory, second neuron will be decussate. Second decussate. Second decussate. Meaning that crosses. Second crosses. So very important. Okay. So let's just review the. This is like a general rule. Okay. So let's review. Let's start with the say. Let me see, dorsal column thing. Okay. Oh, another general rule. Another general rule is that in the sensory, they in reality, in clinically, and in like in real anatomically, the it will decussate in the mid the caudal medulla, right? Caudal medulla. Where is the caudal medulla? So this is a this top part is yellow part is a cortex, and then the middle part is like this part is where is it? This part is let me see. Oh yeah. Let me see. This is not a good picture. Sorry about this. Not this picture. Let me go to another picture. Okay, so not this picture. Let me go to another picture. Say, let me see which picture. Yeah, this one. Okay, good picture. So, uh, basically, what we are concerned is like cortex, brainstem, and then spinal cord, right? So, when they say caudal medulla, in the reality, it goes like the pathway goes like this, smoothly like this. That's the reality. Okay, anatomically this is true, but in terms of exam purpose, okay, listen very carefully. Exam purpose, always think about caudal medulla. What I'm saying is caudal medulla means the bottom of the medulla. Okay, so uh, midbrain here and then pons here, medulla here, right? Bottom of the medulla means it will in terms of the exam purpose, don't memorize it. Okay, as it in the lateral side, it goes toward the medial and then it goes to the lateral again. Don't memorize it. Too complicated. Okay, make it simple. So what I'm saying is, okay, like do you know military terms? Down here and then military terms. Okay, so memorize it this way. Okay, so let me just use another real color here. Okay, like this. Okay, this is the pathway. So at the bottom of the medulla, it decussates and then goes down. So what that means is the difference it makes is that it makes a big difference. Why? Because it doesn't cross here or here in anywhere in the brainstem. It does not cross. It crosses only at the very bottom of the medulla. So what that means is that when I say if there's a lesion was here in the midbrain, I mean sorry in the anywhere in the brainstem, it will not be say in the sensory neurons, right? It just goes up here, right? Sensory goes up here, right? So if I say, oh, the region is in the brainstem, it already passed the decussation. Do you see what I mean? This you have to understand this very very carefully, very well. I mean, okay. So if I say region is in the brainstem, no matter here, already past the decussation. So if it's a region is in here, already past the decussation. Doesn't matter if it's the top of the like very very the like almost reach the like the midbrain and then almost kind of top of the midbrain. Doesn't matter. It already or bottom of the medulla. Doesn't matter. Always brainstem region means after decussation, after process. Okay, so you have to know this very very well. Okay, understand? I'm repeating this very very. I'm repeating many times in this because this is a key point to understand the in terms of the where the region. Where you will have the questions because in the spinal cord and brainstem questions, this is like probably the easiest way the teachers make the questions. Okay, so where is the region? If you see if we suspect anything in the region in the brainstem, that means the pathway, whatever the pathway is, like dorsal column pathway, like the pain and temperature. I mean the vibration and then the proprioception or spinal thalamic tract, it already passed, already crosses. Okay, that's a key point. Okay, understand this. You have to know this. Okay. So, in if it's what if it's the motor pathway, like the corticospinal tract. Okay, so it goes down now, right? Goes down. Same thing. Don't try to understand it like it goes slowly approaching to the like midline and crosses. Don't make your life complicated. Make your life very simple. Crosses at the bottom of the medulla. Okay. If somebody say if some teachers say that okay I didn't say it was like I didn't say where in the brainstem, doesn't matter. Okay, as long as it is in the brainstem, it's the region will be before the in terms of motor in terms of corticospinal tract. If it's a brainstem, it is before crosses. Okay, very very important. It will make your life much much easier. And then teacher will never make the questions that the region is somewhere here that the somewhere here that before the decussation occurs. It will never come out that kind of question. Never make that kind of questions. Okay, I guarantee. They will never make questions. If it's in the even if it's the medulla that the region was like before the decussation, that will never happen. That kind of statement will never happen. I guarantee. Okay, so don't worry about oh what if the region was here? Don't worry about that. It will never happen. Okay, they will not make that kind of that's a so mean question. And actually that's a dumb question too. They will make their own life easy, the kind of difficult. Okay, so uh, just try to understand this pathway. Okay, much easier. Just make your life easier. Okay, so I'm emphasizing this over and over again because like this is so important. Okay, all right. Now there are basically the questions, the very popular questions in the like brainstem and the spinal cord is where is the region? Where is the region? That's a big popular topic in the neurology. Okay, so if it is in the for instance and then another okay let me just draw another picture, another kind of schemical the diagram here, schematic sorry schematic diagram here. Okay, so this is the midline. You all need to know is like only three the pathways: corticospinal tract, motor, and then spinal thalamic, and then dorsal column, the sensory. Okay, dorsal column pathway. Let me use the here. Dorsal column pathway comes in here, and then it just let me just redraw. It goes like this. It I'm so bad in drawing. Sorry about this. And this is a dorsal column, right? It goes in here. Then as soon as it enters the dorsal column, it will directly goes up. Okay. Then they could say that the bottom of the medulla. Okay. So that's the dorsal column. Okay. So I'll use the dorsal column in the pink color. Okay. Dorsal column comes in here and then goes up. Use this color. Okay. Come here, then goes up. Then at the bottom of the medulla, it decussate and goes up to the thalamus. Okay, and then past the thalamus and the past the thalamus and the to the sensory cortex. Okay, so where is the decussation occurs? I mean, where's the first neuron and second neuron? First neuron. So remember that second in the sensory, only second neuron will cross this, right? So this neuron is crosses, right? So this is the second neuron that crosses, okay? And then the after thalamus, it will be third neuron here, okay? So that's the dorsal column pathway. First neuron, as soon as it enters, it just the decussate right here. I mean the switch to the second neuron right there. Oh yeah, sorry. The first neuron just goes directly to here, and then in the second neuron it just decussate. I mean it does the switch to the third neuron. Okay, so first neuron and the second neuron crosses, and then the third neuron. Okay, that's the dorsal column. Now this the spinal thalamic. Spinal thalamic. If you look this, then spinal thalamic will enter here, and then actually in reality, spinal thalamic, it enters, as soon as it enters, it goes like 1 or 2 levels up. Okay, it's the spinal thalamic enters like this way in here, and then there's like some kind of the nucleus called like Lucia or something like that. Okay, so I don't even remember. I don't even pronounce how to do it. LU something like that. Lucius nucleus or something like that. Okay, so from there it will just go up or 1 or 2 levels up, and then goes in. Okay, and then crosses the midline. Okay, crosses like the white commissure, and then crosses or go up, right? But don't in the exam purpose, because that's the although that's the reality, but in exam purpose that the Lucere or something like this, that the nucleus is not very clinically important. Okay, so just so that's why many of the neuro books will just even the exam questions don't even look at those the Lucere's the nucleus. Okay, so just think about when as soon as it enters it, it just the crosses the midline through the going through the like near the white commissure or white the central canal or something like that, and then crosses and then goes up. Okay, so in the the spinal thalamic tract, it will cross it and then goes up. So like this. Okay. So but in the what happens in the as soon as it enters, it just the switch to the second neuron. Second neuron crosses and then goes up, and then in the thalamus, and then it goes to the third neuron. Okay, so that's the sensory neuron. And then now, how about the corticospinal tract? It's the two neuron system, right? So goes down here, and then it one neuron, so one neuron all the way, and then here it just switch to the third neuron, and then this corticospinal tract. Okay, so that's the how the three neuron pathways. Okay, so this understanding this is very 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 important. That's why I'm kind of emphasizing this, repeating this over and over again. Okay, so this will make the this will make your life much much easier. If you understand this well, then the you have a like very good understanding in the brainstem, the like, cortex, brainstem, and the spinal cord. Okay, so now how about cranial lobe? Okay, if I say cranial lobe, okay, let me ask this kind of tricky question. Okay, if I say I had a region in the spinal cord in here. Let me just. I had a region in the spinal cord here. Okay, region here. Okay, what cranial lobe will be defected, the impacted, affected? If I had the spinal cord, what cranial lobe will be affected? Do I even have an affection? I mean, impacted for cranial lobe? Any impact on the cranial lobe? Anyone can answer? Okay, I'll give you the answer. I'll give you the hint. Okay, in reality, only one exception that the cranial nerve 11, accessory nerve, has a spinal cord pathway briefly. Okay, but that's very very kind of rare exception. You don't even think about it. So cranial nerve, no spinal cord involvement. Okay, because by definition, cranial means like the brain. I mean the head, right? So why would the pathway will go down to the all the way to the spine? It's not going down to spine. Okay, it's just brain from brainstem goes out directly. So cranial. Let me ask you another very important question: is cranial lump the CNS or PNS? You can answer on mute, or you can just write down on the chat. Is it cranial lobe is the CNS or PNS? Very important.
Same.
No, that's the main mistake. It's a very popular mistake that people make. I was even thinking that cranial lobe is CNS. No, cranial lobe is PNS. So cranial lobe has a two part. Okay, upper motor neuron and then lower motor neuron. Upper motor neuron is CNS, but lower motor neuron is a PNS. So cranial lobe, if someone asks is cranial lobe the PNS or the CNS, you have to say two part, upper motor neuron and then lower motor neuron. Upper motor neuron is inside of the spinal cord. I mean inside of the like, brainstem, the that pathway. So basically, this one, all are CNS. Okay, and then cranial lobe is right here. Inside of this one has a upper motor neuron part of CNS, and I mean of cranial lobe, and then after that coming out, that's a PNS. It's a lower motor neuron. It's PNS. Do you understand this? This is very very important. So as I told you, the with the exception of very very the rare exception, which is like cranial 11, which has a spinal cord pathway, forget about that. Okay, so all cranial nerve directly coming out of the brainstem. All right. So if there is any lesion in the spinal cord, it will not affect the cranial nerve. Okay, very important to understand. Okay, all right. Now, now many of you will have the question, like very very difficult time to understand to answer the questions about ipsilateral, contralateral, right? So I will make it very very simple for you. Probably this is the simplest form of to understanding it. Okay, so if I cut, okay, if I cut these are three pathways, right? So if I cut, let's start with the dorsal column, okay? If I cut it in the here, the spinal cord, where if the cut is right here, if the region is right there, then would you expect the ipsilateral, which means say this is the right and then left, okay? So if I have the region in the right side of the dorsal column, this is a pink line here, okay? So then would you expect the I have a right side problem or left side problem? In other words, the can I detect the pain and temperature I mean the vibration sensation from right side if I have a lesion right there in the spinal cord? What do you think? Do I can you have a impact on the right side of the like vibration sensation? You know, for my memorization, I I use the MVP for minute the touch, and then vibration and proprioception. This is a dorsal column medial limniscus. I use the same terminology MVP, and then also I use like a pain and temperature is for the spinal thalamic tract. Okay, so anyway, so if I had a lesion in the right side, right and then left, okay. If I had the lesion in the right side, then do I have a impact on the MVP on the right side? That's my question. What do you think? Impact? Yes, yes. That's simple because you know the from this picture. Basically, all you need to do is just to draw this picture, and then everything will be easy. Okay. If we have the region right here, yeah, you see right there, right? We have right side will be impacted. How about if I have a region in the brainstem? What's going to happen? In the right side of the brainstem, do I have the impact on the MVP? Right, region right here. Yes or no? In the right side of the brainstem, do I have the right side of brainstem? I'm right side of the MVP problem. Region is right there, and then the pathway goes right here. Do I have a region here? Then does it affect the MVP sensation on the right side? Yes, good, good, good. How about if I have a region in the right side region in like the cortex? Okay, if I had a region here, do I have a? Oh, by the way, oh yeah, I'm sorry. One mistake, one big mistake I made in here in drawing. In drawing, I explained it correctly, but I drew in the wrong way. Okay, so let me correct it. So this was the brainstem, okay? And then this was supposed to be a cortex. Sorry about that. Cortex. Okay, and then so I will just draw this one. Yeah. So right side, left side. Okay, so brainstem, the bottom of the brainstem is where the decussation occurs. Okay, so this is a correct picture. Forget about the previous picture. I made a mistake in here. Okay, so spinal cord, brainstem, and then the cortex. Okay, so sorry about this. So if I made a mistake, so what did I answer? Yeah. Oh, yeah. So let me ask. Also, in my previous question, let me just rephrase it again. Okay. Sorry about that. So if I had the region in the right side of the brainstem, do I have the does it affect the MVP in the right side? No. Yes. Very, very important. No. Right? That's very important. How about in here? Do I have a region in the right side of the brain, right side of the cortex? Does it affect the MVP on the right side? Nope. Yes. Very, very, very important. Critically important. Okay? You have to know this. So in other words, you have to draw this. All you have to do is in the first 15 minutes, you just draw this picture exactly the way I drew. Okay? Then everything will be like super easy. Okay? Let me use another one for another example for the spinal thalamic drug. Okay? Now the blue line here thing. Okay? That's a spinal thalamic drug. Okay? So uh, no, and I'm sorry, in the spinal thalamic issue, in the black line, this line, this line right here. Okay, that's a spinal thalamic issue. Okay, so now, okay, let me ask you the questions. If I had a lesion in the spinal cord, right, say in the right side of the spinal cord here, do I have a impact on pain and temperature sensation? Remember this the spinal thalamic tract. I drew it in here in the with the black line. Okay. If I had a region in right side, do I have a pain and temperature problem in the right side, same side, ipsilateral side? Yes or no? No. Yes. Good. 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 You understand that because the black line doesn't get involved even if I have a spinal cord problem. Okay. So what if I have in here? Does it have any problem? If I have a right side brainstem, does it affect? No. Yes. Good. Good. How about in the cortex? No. Same thing, right? So let me write it down here. The spinal thalamic tract, and then dorsal column here. Um, uh, Let me just the instead of using the ipsilateral contralateral is assuming you just know this the draw you just draw this picture in the like the the how do you call it whiteboard or something like that in the during the 15 minutes. So okay, so spinal and then cortical spinal tract. Okay, so if it's a spinal cord and then brainstem and then cortex. Okay, then spinal cord, the if the region is in the right side, okay, right side spinal cord, the in the what did I say? Okay, let me just why don't I because we start with the total column first, right? So the total column was in black. I mean the pink, the purple color here. So total column, and then spinal thalamic tract was this color here. Okay. So dorsal column, we said that the if the region was the right here, spinal dorsal column, which is we are pink line here, right there. So if the region is right here, then you have a problem, right? If the region is right here, no, no, right? So the I'll write here, yes. So the right side problem, no, no, right? And then how about the spinal thalamic tract? Then we had this black line right here, right? So it will be no, 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 right? So I will use this color here. No, I mean, so no, 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 right? So how about the lastly, the corticospinal tract? If I had a lesion in the right here, in the corticospinal tract is in the this one, and then the blue thing, blue one right here, right? Okay, so if I had lesion in the spinal cord, does it affect the spinal? Has an impact on the right side of the corticospinal tract? Yes, good, good, good. And then here, no, no, right? Remember this one, this thing is just the bottom of the medulla. So as soon as I had the region, that always means that it's above, the region is above this the crossing. Okay, so corticospinal tract is only when the in the same side it is affected. So right side affected, and then no, no, right? Basically, all you need to know is this table right there. Okay, right side has a region in the corticospinal tract, only dorsal column, and then corticospinal tract has a right side problem. Everything else is normal. Let's just go one more step. How about cranial lobe? Cranial lobe. Okay. Remember, I said cranial lobe is always not in the spinal cord, always in the brain, come out of the brainstem. Okay. So, and in the corticospinal tract, I mean the cranial lobe is always ipsilateral. Okay. So what if I say the lesion was in here? There was no no cranial lobe coming out of the spinal cord. So it will be just it will be no, not impacted. Okay, let me just just rewrite. My handwriting is terrible, terrible. Okay, so there's nothing affected. And then how about in the brainstem? If the lesion was the in the right side, the cranial lobe basically all ipsilateral. If the lesion was right there, then coming out of here, okay, upper motor neuron and then lower motor neuron right there. Okay, let me just draw it. Why don't I just draw it here, right here? Okay, so it will be I'll just draw it here. So here, here, okay, that's a cranial lobe. Okay, so if I had a lesion right here, then does it affect in the right side? The right side of the cranial lobe affected? Yes, good, good, good. So cranial lobe right side is affected in the when it's in the brain stem. How about lesion was in here, right side of the cortex? Is it affect on the right side? Yes, perfect, perfect. Okay, so right side. Okay, so this is a table that you need to know. All right. Once you know this, basically you just in the first 15 minutes you just draw this simple chart, simple diagram, and then just simple just this table. So simple, right? So the thing affected in the ipsilateral side, dorsal column, when it's in the spinal cord, and the nothing affected in the spinal thalamic tract, and then corticospinal tract on the spinal cord, and then cranial lobe when it is in the brainstem and or cortex, it is affected in the ipsilaterally. Otherwise, all contralateral side. So easy, right? So this is like you might not take a screenshot of this one. Okay, so this this the analog. I mean this not analog. This the understanding this will just make you big advantage in terms of timing. Other people will just make a hard time. Okay, if it's the try to memorize thing, it will take forever. Okay, and then this one you will never make mistakes. Okay, all right, good, good, good. All right, so I spent so much time on this the one topic because this is so important, and just make sure that you understand this crossing always occurs bottom of the medulla, and that means that anything region in the brainstem, all level, which doesn't matter, midbrain, pons, and medulla, always above the decussation, above the crossing. Forget this thing here. Always military tone, like military. You know military tone, right? Military tone like this. No, this kind of like how do you call it? I don't know, the jag walking or something like that. So okay, all right. So basically that will just cover everything, everything in the spinal cord, brainstem, everything is there already. All right. So I'll just move to the next topic, which is going to be the this one. Okay, let me ask you a very philosophical question. Uh, when is your most important time in your whole life that just changed the whole life? What was what was the event? When was it? When did it happen in your whole life that your life changed? When you entered in the medical school, when you entered in the college, first few weeks of the MBA, yes, that is absolutely correct in terms of the question as a medical student. Okay, so it's not the first day in your life, or it's not the first day of your the medical school. Okay, it's the 15th day of or 18th day of the embryology. Okay, when neurulation occurs. Okay, so before that, you are not really your body is basically the like a zygote, and then we don't really call kind of the living creature, living being. Okay, so after this, your body is trying to your kind of things which was like a zygote is kind of differentiated. Okay, now starting differentiated. So this one, after this moment, then your life is like a really kind of functional. Okay, so now I do not discuss whole thing about the embryological process. I just want to focus on this thing. Look at this the neural crystal. I think I have one more picture. No, yes, yeah, this is probably better picture here. Okay. This one, this screen, focus on this screen thing. That's the neural crest, okay? Neural crest is the one. Remember the neural crest is the always bothering us, right? So, because everything else is kind of, a lot of things are neural crest cells. Because ectoderm is kind of easy to understand. Every ectoderm means a kind of outside. So, like, kind of something like skin and stuff, right? The epithelial cells, that kind of stuff, right? So epithelial cells is basically in the tube, any tube like the GIT. Outside means that this cells in outside, okay, epithelial cells. It's kind of outside, right? In outside the body, because this is mouth, and then this is anus, and this is whole tube is just outside of inside of it is inside of our body, but actually it's outside. Same thing for the like the vaginal canal, and then the like the fallopian tube, and this one actually is outside. It's not, it's connected to the outside. Actually in fact, this thing is vaginal canal, and this thing is connecting inside the body, outside the environment. It is just connecting like this. So it's very, very weird thing, because this one is a mouth to anus, both outside, right? This is inside and outside. This is very, 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 very strange thing. So that's why women are always strange, right? Okay. Anyway, so so that the GIT here is epithelial cells. In other words, that is outside. So it's kind of ectoderm, right? You understand? Very understandable, right? So also endoderm is kind of understandable too. It's like endo means inside. So something like a blood vessel. blood vessel is inside of our body, right? So because inside here, inside, connected inside, right? So blood vessel is basically inside of our body, right? So endothelial cells, endothelial cells, okay? So whereas the tube in the GIT or vaginal canal, that was epithelial cells, or same thing for the like PCT, DCT, or lupobelly, and that kind of things, right? Epithelial, so it is outside of cells. This is inside of the cell, okay? So anyway, so the neural crystal, so endodome, ectodome is kind of easy to understand. Mesodome, yeah, kind of understand. It's kind of, it's a middle layer, right? So anything kind of not in the like skin here, say skin here, and then GIT here, and then other like blood vessels here, and then there are some kind of parenchyma, right? So parenchyma means like including the blood vessels and some kind of connective tissue, right? So those parenchyma is all kind of mesodome, understandable. But neural crest is really bothering us because it just goes everywhere. It's not just staying, kind of, it's just it's not staying in one piece, and then it's just like growing from here. It just basically, see, look at this. This guy, this guy is in the middle, and then this guy so forms a kind of layer here. And then now it's like a kind of, if you look at it from the front, it will be just a, kind of this the two kind of, unpredictable thing. Okay, so it's just ready to roll, and then as you grow, it will just go everywhere. Okay, it goes PNS, and there are many places it goes. So that's where our life started. Okay, so 18 weeks is the beginning part of our the life, and then basically in the real life, I mean, and then the neural crystal forms from this time, okay, and then neural crystal, the easy way to remember is a motel path, right? So you can just look it up from the internet for motor path mnemonic. Okay, so this is like a very the keep bothering you, and then it will keep bothering all medical school students throughout their life. Okay, so you need to know that. Okay, another thing important also is this is also important. Dermatome. Okay, Tomatum is, why is it so twisted and like this? It's not, why is not straight line, right? Have you ever wondered this? Why is not straight line? It's over here is okay, but why is not straight line? Why is it kind of going this way? And then the here it goes this way, horizontal line. That's okay. And then why is it circling here? Why is it going diagonal here? And then circling here? What happens in here? Do you know why? This is answer. So if you just draw the picture like this, see this here? Everything is a horizon. Everything is vertical. I mean, everything is vertical. Okay. So if you imagine this person is kind of bending over like this, crawling position or whatever the position like this, bending the flexing position like this, then the tomatum will be distributed in this the vertical lines. Okay, so trying to kind of figure this person as like a the bending over his back like this. Okay, so just for the tip. All right, where I okay. So that's the thing. Okay, now now basically now is the time to start the real the med four stuff. Okay, so med four basically is like the difference between med one and med one, I mean med three stuff. I mean, so med one was basically you learn the neuro too, right? They focus on anatomy, and then in the med 3, they focus on physio, and then pathology, and then other pharm, of course. And there are not many the neuro the micro, but also micro too, right? But the more important thing is like a physio and farm. Okay, farm and the micro is also important, but in terms of the as compared to other systems like a GI and then respiratory, very very heavy in micro, but in the neuro, like there are some micro, but not very very heavy. Okay, farm also heavy too. Okay, because neuro is something to do is very related to the psych. Okay, psych has psych always farm. Psych is farm basically. Okay, so very very important. All right, so now, so every time you see some kind of new the like disease or symptoms or syndromes, okay, you have to kind of you have to kind of like try to capture the like keyword. Okay, so while I'm going through this is very very many pages, like the other about 100 some pages. Okay, 104 pages. There's no way that I can. My mind is now be blown. Okay, so it's I cannot like in 3 hours, I cannot cover every detail of the topics, of course, right? So what I'm gonna do is I'm gonna just like the keyword that you need to know. What the way that I like to highlight. Like I'm gonna do like for instance I'm gonna do like use this the marker. I mean the highlighter, and then neurosyphilis, and then I'm gonna just the tabes totalis, and then the like this broad-based this is I'm gonna highlight like this. Okay, so the way I do is like I just skim through this page here, and I just copy down this page from the boot camp, and then I'm gonna skim through this page, and then oh, this one I know, I remember this word, I remember this keyword, remember this association. That's how I am going to the highlight. So that means that those points are very important. Okay, if it's not important, I would be already forgotten everything, right? Is it correct? Right. So that's what I'm gonna do. Okay. So and then also if there and whenever there's some kind of the explanation and some understanding is needed, or it might help you understanding, then I will explain. Okay. So that's what I'm gonna do. All right. So here tertiary syphilis. Okay. Tabes totalis, tertiary syphilis. Syphilis is the treat with the penicillin. Okay. So tertiary syphilis. Okay, and then one thing important thing is the tabes totalis. It's called tabes totalis. The symptoms is like the probasis, ataxia, and then Lomborg. Okay, so I will come back with the Lomborg signs. Okay, what the Lomborg sign means. Okay, and then another thing, important thing is that because it's a tabes totalis is like this, then like this. It will affect the this dorsal column part, right? So that's why it is affecting proprioception. Okay, loss of so proprioception, MBP. When I say MBP, minute touch, vibration, proprioception. Though there is no such a thing in neurology that oh I lost vibration sensation, but my proprioception sensation is okay. There's no way. There's simply no way in exam purpose, in clinically, no way you can do that. So MBP always go together. Pain and temperature always go together. with the exception at the beginning of this class, I just said you, I just told you like a little bit about exception, but kind of rare effect, rare exception. Okay, pain and temperature go together, NBP go together. All right. So now, uh, so another thing is that the important about the neurosyphilis is that the Argyll Robertson pupil is Argyll Robertson pupil means that accommodate. Sometimes it's called prostitute. Let me write it. Prostitute the pupil. Why do they call prostitute pupil? Prostitute is, basically this is a little bit of kind of, the rated R, but the prostitute simply means like, they just take everybody, right? So they can accommodate, but they don't respond. They don't respond, no respond. So what that means, what accommodation means? Accommodation means that the accommodation is kind of uh, not well defined term. Okay, so here they say that when the pupils constrict when the near object, that some books say this is accommodation. Some books say um, the when the finger is the closest, then it goes like this. That's accommodation. Some books say, okay. So that's accommodation too. So it's not really the well like clearly defined term because of some books say different things. Okay, so but say we'll just follow this this definition here. Accommodation is there, but if you write doesn't respond. It's not. It's supposed to be like a. If you write it, then pupil is supposed to be like this. Let me redraw it here. Yeah, pupil is supposed to be like this, right? So this the light shining, then it's supposed to be like pupil is supposed to be shrinking, right? That's the reaction, reactive. So respond. So it's supposed to be pupillary respond. It's not there. So that's why it's called the accommodate but not respond. Okay, so that's why it's called prostitute the pupil. All right. So that's what the neurosyphilis. Now Guillain-Barré. First, I had a hard time to pronounce it. This Guillain-Barré is okay, but Guillain, why is it called Guillain? But it's kind of the Spanish origin, I think, the pronunciation, whatever. Okay. One thing you need to know is this thing. Guillain-Barré, ascending symmetric flaccid paralysis, that's understandable, and then only in low motor neuron. Okay, so what do you mean by this low motor neuron? What do you think? Low motor neuron means it's kind of PNS. Upper motor neuron is not PNS. All low motor neuron has to be PNS. Okay, another name for low motor neuron is alpha motor neuron. Okay, in terms of the skeletal muscle, it's called alpha motor neuron. It's same as low motor neuron. Okay, so know this. Okay, so it is a PNS, and the one thing you need to very high yield is the Campylobacter jejuni. That's the bug that is the most common, appears in the exam. Okay, but in reality, this can other bugs can cause this. Okay, so notably, cytomegalovirus is the most common virus, and then also the Staph aureus can cause it, or other things can cause. But Campylobacter jejuni, you in terms of exam purpose, you need to know the Campylobacter. Okay, Campylobacter occurs the Guillain-Barré. Okay, so Guillain-Barré, Campylobacter. Okay, and another thing very 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 important is albumino let me use this color. Albumino cytological dissociation. What does this what does this mean? Albumino cytological dissociation. What this means is that it's a protein and the think about this. This is a CNS problem or PNS problem? PNS problem, right? So if you look at what this means is that if you look at the CSF, what do you expect the like IgG level in the CSF? In the this is a PNS problem. Where is the CSF? CSF is covering PNS. I mean, sorry, CSF is covering PNS, right? Sorry, I keep saying PNS. CSF is covering CNS, right? So this has nothing to do with CNS, only PNS. So CSF has some kind of changes in. Do you think of the CSF have many immunoglobulins there? No, because it's a PNS. PNS is not covered by the CSF. Only CNS is covered by the CSF, right? So CSF has a no IgG increase. Okay, what I'm explaining here is not completely scientifically correct, but for the purpose of understanding, this is why I am explaining to you. Okay, so and then also it will be correct in terms of exam purpose. Okay, that's why I explained to you. So because of PNS problem, no IgG increase in CSF. Okay, so this is what that means. Albuminocytological dissociation simply means no IgG the increase in the CSF, but let me just a minute. Let me just kind of cheat a little bit because no. Let me see. Just a minute. The neuro document better. Neuro. Just a minute. Let me just cheat one page here. Just a minute. It's in the neurology. How can I page? Oh, let me see what page is this. So doesn't say the page is okay. Just a minute. Let me just cheat one page here because this is important that I need to. I don't want to give you the wrong information. Okay. So brainstem, the midbrain, the lower pulse. So Campylobacter. Can I search it here? Campylobacter. I mean Guillain-Barré. Okay. Guillain-Barré. Oh, Guillain-Barré syndrome right there. Okay. So this is the protein is increases. Okay. Right. Okay. So this is what it means. Okay. Right. So let's just go back. Oh. Let's go back here and then here. Right. Okay. So protein level is increased, but no the inflammatory cells in the PNS and CSF, but protein level increase. That's what albumino cyto dissociation means. Protein increases, but no inflammatory cells, no antibodies increases. Okay, so albumin means protein, but no inflammatory cells. The reason that albumin level increases is there is an inflammation, right? Because this is an inflammation, right? So infection occurs. Body try to fight, with the infection, the bacteria, right? So what body does is making some kind of any kind of protein to fight some, making some the immune cells, and those are all proteins. Cells are basically made of proteins, right? So body try to make a lot of proteins, but so you will see the some other in the CSF you will see some other proteins, albumins, because albumin is the most popular protein, right? So we will see the protein, so albumin inside of the CSF increase, but no actual antibodies is coming into the CSF, because it's not the problem with the CNS, it's a problem with the PNS. Okay, do you understand this? Understanding this will make your life much easier, and then this will be easier to understand rather than okay, albuminocytological dissociation, just memorizing these names. Okay, so also that's the also similar logic will happen in the poliomyelitis. Polio is what? Polio is what's the polio? Is it the CNS problem or PNS problem? Is polio CNS problem? Do you know polio, right? Okay, is a polio CNS problem or PNS problem? Polio is also no. Polio is also CNS, PNS problem, because of low motor neuron problem. Okay, polio is the same thing for the Guillain-Barré. Okay, so polio and the Guillain-Barré both are PNS problems. Okay, so because it's PNS problems, exactly the same thing. So CSF, if you look at the CSF is only for the CNS. So if you look at the CNS, the no immunoglobulin coming in. So there's no, because there's nothing like a CNS problem. So, but if you look at the protein, because it is the inflammatory process, it is an infection process. So body will try to make the cells, not antibodies, but cells. So cells are basically protein. So body makes the protein, but body doesn't. The antibodies will come into the CSF. Okay, understanding this is very important. It's like a very unique in the polio and then the Guillain-Barré. Okay, so the management is also important, because it's not the problem with the because it's not the problem with the immune response. Okay, so no, it's not a problem immune response. So you don't use the corticosteroid. This is not autoimmune. It's basically infection. Okay, so infection, you don't use because if you use infection, what's going to happen? If it's infection, you use the steroid. Steroid will reduce the immune response, right? You don't want to that. You want to find the more inflammatory cells to the fight against the infection. Infection is a bacteria. Okay, whereas the polio is the virus, like a RNA virus. But this one is the positive sense RNA virus. But the Guillain-Barré is a bacteria, gram-negative bacteria. So it's a infection. So you have to fight. So you don't want immune system to be low. Okay, so that's why it's a low. I mean, no corticosteroid. Right? That's important. Right? Marcus Gunn people, multiple sclerosis has a, I think it's the next page. Okay, multiple sclerosis. You remember this one? Young female, yeah, especially the white female, young white female, optic neuritis, and then this is a painful. Okay, painful, and then usually unilateral. Marcus Gunn pupil. Marcus Gunn pupil is basically if you are like going for the neurology more in detail, you will learn kind of relative apparent the pupillary defect. But let me explain very like layman terms. Marcusson pupil, and then the Argel, the Robertson pupil. They're basically very, very similar. Okay, so like in fact they have like same the kind of pathophysiology. Okay, so what happens is the reason they do have this kind of the weird syndrome is for instance here you have a you shine here the you yeah, this is a pupil. Okay, and then you shine light here and then switch here and then come back. Okay, then what happens is this one, if we have a problem here, okay, so this one is not the like supposed to be the is normally it's supposed to be going like narrow if you shine it, right? If you shine, then it is supposed to go like this, right? That's a normal. And then going back and forth is that what happens is that this one, it will become like the, and then come back. It will go here and then come back. It will become large. Why? The reason behind is that it's a delayed reaction. So what happens is that this the neurons that the innervate the radial muscle and then the ciliary muscle, those things that the controls the pupillary size, right? That those neurons are delayed reaction because it's not responding because those basically those neurons are like the damaged, so it doesn't respond quickly. So it's supposed to respond very quickly, but it doesn't respond quickly. So that's why it delayed. So if you go here and then come back here, then by the time you comes back here, it will just oh it was like the no light in here. It delayed, so when it comes back, oh it was no light. So I'm my the pupil will be large, but when it comes back, that's why it becomes large. But it's not because of the it's doing opposite reaction, but it's kind of delayed reaction. Okay, so understand that way. Okay. So that's what the Marcus pupil cones. I mean Marcus cone pupils, okay, or the Agile Robertson pupils. They are basically same thing, okay. All right. Another thing is that the internuclear ophthalmoplegia. This is a problem with the MLF. That's the because of the reason that MLF is because of, this is basically demyelination problem, demyelination in CNS problem. Okay, so what's going to happen if it's demyelinated? Demyelinated means that the neurons are covered with like a kind of fatty materials. Fat is the white, so it will be covered with like a kind of fat materials. So fatty kind of covering. So in other words, the neuron is like this, then covered with the fatty materials like this. So um, this is covering. It's kind of the not conductive. So non-conductive. Only this part, this part, this part is a conductive. So what's going to happen? So the conduction will no conduction in here because no, it's just a covering. So no conduction, it goes very fast. Inside, it's just a don't bother with the outside the stimuli. It's just a don't bother, very fast here. Then after this, it will just the action potential will be here, and then jump to here, the like one stop here, second stop here, third stop here, like this. Okay, so this is called saltatory conduction, jumping conduction. Okay, so that's what the myelinated the neurons will do. Okay. All right. So another thing, because this is important, that's why I'm going to highlighting many things in here. Okay. It's not because of the I have a good memory, so I highlight everything. Okay, it's not because of that. Okay, okay. And then another thing is that the Althoff phenomenon. Althoff phenomenon, and then also the you have to know this one too. The Littman sign. This one is uh, like hot walls. This one electric. So you have a like kind of like electrifying sensation. That's the Littman sign. Littman sign. Okay, and then ortho phenomenon means the your symptoms will worse when it's hot. So those people who are rich in but has a multiple sclerosis usually have two houses, one in cold area and one in Arizona. So in winter time they go to Arizona, and then summertime they come to the like, northern part, so Nova Scotia, like that, because of the summertime with their like their symptoms will be very bad. Okay, so only upper motor neuron science, because this is a multiple sclerosis. Where is the region? It's in the brain. Where? In the periventricular calcification. If you take the MRI, periventricular calcification. Okay, and then treatment is going to be the interferon, the beta. Interferon, not gamma, not alpha, interferon beta. That's the like mainstay of the treatment. Okay. I'm not sure whether it. Oh yeah, here, and also yeah, also the natalizumab. Okay, natalizumab is a famous the like kind of the monoclonal antibody that has a that can have a PML, progressive progressive myelinated the neuropathy, leukoencephalopathy, yeah, progressive multifocal leukoencephalopathy, PML. PML is due to the like reactivation of the JH virus. Okay, all right, very important. Reactivation. What does reactivation? Let me see if they have a. No, they don't. Okay, reactivation. What does reactivation of JH virus will do? What do you? How can I say? Um, what's going to happen here is that I told you. I think I discussed about the TB virus, TB reactivation, right? So did you remember that I told you about the like granuloma, case-shading granuloma. So case-shading granuloma simply means that the macrophages, when the TB comes in, and then macrophages is basically don't recognize the TB virus, and then he doesn't know what to do. So macrophages will basically at the beginning the T cell will kind of activate the macrophage. Macrophages to try to fight with against the TB, but TB is kind of the strong, so it's a strong bacteria. So macrophages cannot kill all of them. So they will just basically the TB comes in here, and then macrophage, the activated macrophages comes in, try to fight against the TB, but they cannot kill all of them. So so they will form. Okay, let's team up. So macrophage 1, macrophage 2, macrophage 3, they'll team up together. Then they make the multinucleated giant cell. Multinuclear giant cell here, another multinuclear giant cell here, and then they try to fight against the TB. Some TB died, and some TB survived. And then the before the macrophage comes in, and then T cells was activating the macrophage. Also at the same time, the neutrophil comes in the beginning part, and then neutrophil is fighting against the TB2. They are big battle here, and then the neutrophil died. Some neutrophil died, and then the neutrophil may eaten. I mean, ate the TBs, and then also macrophages ate the TBs. So there are some dead TBs and the alive TBs, and then macrophages died, or the giant multinucleated giant cells there. All these things are inside. They're all mess right now here. They are basically, now think about the Gaza Strip. This is like right now, some people are hostages and some people are dead, and a lot of some fighters against the Hamas, and then Israeli Hamas, like that kind of mess, right? So, and that mess is like surrounded by wall of by the team of macrophages, big wall. This whole thing is called granuloma, oma, okay? And then inside there is a live bacteria inside. If there's a live bacteria inside, this granuloma is called caseating granuloma, which is unique in the TB or histoplasmosis. In two cases, among other things. Probably there may be more, but we don't know that, and then that's not very very common. So TB and then histo, the caseating granuloma forms. Okay, so think about like a Gaza strip. Okay, so JC virus is also kind of reactivated from similar the mechanism as a caseating granuloma. Okay, not exactly the same, but you can just think as like a kind of, whenever you see reactivation, why is it reactivated? Because of the one the immune cells that walled off is now wall is broken. Wall is broken, then it will be reactivated. Okay, wall broken activity. So wall breaking the substances, wall breaking drugs is going to, it's a natalizumab. It's a wall breaking drug. Wall breaking drug. So TNF alpha is a immune. It will activate the immune. I think Alex told you that it activates the immune systems, right? So it will activate the immune systems. It will means that it will activate the inflammatory process. Okay, inflammatory process means that body try to fight for us. So walling off is wall off is or forming the multinucleate giant cell. All those things are the immune inflammation process, which is a inflammatory process, and then immune systems, and then it's due to by all caused by the TNF. Okay, so now TNF alpha inhibitor will be decrease the, it's doing the opposite. So walling off is broken. Multinuclear giant cells broken. Inflammatory is broken. So it will be no wall is broken. Basically, Gaza Strip was like surrounded by Israeli armies. That Israeli army was like also maybe they did okay peace treaty or something like that. Okay, so maybe the suicide bombing. So the wall is off, and then now that the Hamas, the people, Hamas armies can come out, right? So that's what the situation is. Okay. All right. So so much time in here. Okay. So that's a reactivation of JC virus. Okay. So PML. Actually, I personally saw this the one of the patient was like this PML patient, which was very very rare. But when I did the neuro rotation in Chicago, I saw this. So this this is exactly the like the MRI that he had, And then we first thought that because this was kind of rare, but the also usually the HIV patient they are more common for the PML, but this guy he's about the 70, 60 some ages, and then had no risk factors. He never had the HIV. He never drank, and he was like completely healthy. And then all of a sudden he started having the dysphagia, and then he was like the Wernicke's dysphagia. Wernicke's dysphagia means that he was making some word. So basically he was like making stories. Wernicke condition, right? Alcoholics, right? So he was making questions. So for instance, if I ask, okay, what's the today's like? Today's weather like? And he was, my son is going to school and he had a party. He's just make when he doesn't answer my question. He just make up the story. Whatever I make ask questions, he just make up the story. He never stop talking. Okay, so that's the one his like dysphagia, and then he was like he had that kind of symptoms, and then took the MRI, and then he had the JHI, I mean the PML. Okay, so it's a very very rare event, but I had the experience. All right, so there are other conditions, other demyelination conditions like Charcot-Marie tooth, CMT. So it's also PNS. PNS has to be low motor neuron, okay? And then like metachromatic the leukodystrophy is one of the, I think this is one of the cause that this one is in the biochem. It's the biochem, one of the pathway. I'm not sure. I'm not very good at biochem, but if I remember correctly, like BH4, that kind of things. Okay, so you don't need to know every detail of this thing, but I think so. If I have a chance, maybe in if you may some, I think so, the doctor was the Canadian guy, doctor, not the Dr. Close, doctor in the first year of med one, there's like some Canadian professor, right? So I think James, not Dr. James, he's I forgot his name, but he will teach he will cover this one of the this pathway. So the pay attention to his lecture. He will discuss about this thing. Okay. And then also another thing is central pontine myelinosis. This one is kind of important because it causes a Larkin syndrome. Larkin syndrome, you know what Larkin syndrome means? Larkin syndrome, in terms of the symptoms, very, very unique. All but eye paralyzed. There's a horrible story about in the one of the nursing home that one girl, I think she is like maybe in her 30s, was in Larkin syndrome. Okay, so basically he was like a central pontine myelinosis. So due to the like, she had the hyponatremia, I think, and then with us so they like try to lower the I mean hyponatremia, and then they try to increase the sodium level too quickly. Okay, so then too quickly rotation will cause a Larkin syndrome. Too too quickly the control hyponatremia will cause the demyelin, I mean the central pontine edema. Okay, so edema and then demyelinosis. Demyelinosis. Okay, so anyway, so in this one becomes the Larkin syndrome. Okay, so she was Larkin syndrome, so she cannot move up all of her body except her eye. So only the eye is moving. She was still alive, of course. He was alive, but simply cannot move. And then the one of the caregiver was like raped her repeatedly. Imagine that. It's a very, very horrible story. You are being raped, and then you cannot talk, you cannot do any body movement except your eye. It's a horrible, horrible story. That actually this happened in a couple years ago, I think. All right. Another thing is that subacute, subacute, the sclerosing encephalopathy. This one, all you have to know is measles 20 years later. You had a measles infection, and then the 20 years later, this the subacute sclerosing happened. This one, SSPE. This is SSPE. Okay. So all you have you have to know the measles. Okay, 20 years later, and then also the reason that I brought this page in was try to understand, try to explain about this thing here. Action potential. This action potential happens here. Depolarization. What does depolarization mean? Depolarization means the polar means that the more negative, more negative means polar, more hyperpolar, more polar. Okay, and then dipolar means less negative. It's a dipolar. Okay, so less polar. Okay, so less polar. From here, as compared to here, it's a less polar, right? So come here, less polar. But less polar doesn't mean it will be depolarized, because it has a threshold. It has to, you fail the depolar because it's not strong enough, not strong enough. And then once you pass that threshold, then it will be depolarized. Okay, then action potential occurs. That's the normal situation for all kind of neuromuscular junction. I mean the neuromuscular junction, the neurons. Usual functions for the skeletal muscles or the smooth muscles happens in this way. Action potential occurs in this way. Okay, so the initial dipolar, and then but it doesn't reach the threshold. Action potential will not occur. Only after you pass the threshold, it will be action potential. There's no thing has okay past strong stimulation, not action potential. This doesn't happen. Same action potential as long as you pass the threshold. Okay, something that you need to know. But if it doesn't reach the threshold, it will be just a failed depolarization. Okay, so there are some toxins that gives like this problem. For instance, the sugar toxin, and that will kind of depolarize state very, very long time. It's just basically the like sodium channel is like the sodium stimulus is like, this is the sodium channel, right? And then sodium channel is like it's not really inhibitors of sodium channel, but somehow that inhibitors sodium channel closing will be inhibited. Okay, so it will be just keep opening. So it just happens. Action potential happens all the time. So it will be paralyzed. Your body will be just continuously like stimulated. Okay, so it's not good, of course, right? So there's a kind of flaccid paralysis occurs in the sugar toxin. Okay, so you can kill people. Okay, so all of this can kill people. Okay, and then tetrodotoxin is kind of opposite. It will be just don't reach it will be always like this, failed initiation, right? And then lidocaine is kind of the same thing. So basically this and same, then this is opposite. Okay, let me just write in here, same, and then opposite. opposite. Okay, and then so chloride channel. Chloride channel is, you can think as a chloride channel in the GABA. There are like there's like I think there's like 9 different kind of channels or something like that. Okay, so don't just don't take a big the this thing. Don't take it. It's a kind of, there's some kind of 9 channels or something like that. Okay, then out of that there's like a chloride channel. Okay, this chloride channel can be like stimulated when this chloride channel is stimulated. That is how that the GABA functions. So GABA is kind of inhibitory protein, right? GABA and glycine, those are inhibitory protein that makes the for you to relax. Okay, so for instance, alcohol works in here, opioid works in here. Okay, so uh, the problem is the potassium, I mean the chloride channel can open in can be stimulated in 2 ways. Okay, it can open as the benzo or barbiturate. Okay, and then benzo increase the frequency, whereas barbiturate increase the duration instead of frequency. Okay, so 2 ways, and then they will ask these questions: is it increase the due to the increase of frequency or to increase the duration? The way you remember is this: benz is a, it's kind of man, right? And then Barbie is a female, right? So Barbie, I mean, men basically care about number of times. Okay, I did like 5 times last night in terms of sex, right? So that's what the man cares. Okay, I don't care about the quality. I just do care about like number of times. I did 5 times last night. Oh yeah, that's really good, right? But then in the females don't care about the number of times. They do care about the like quality. So they, oh yeah, had a really, really like nice, really best sex in the world last night. So duration is a big thing, right? So that's how you remember. Female, barbiturate, female, duration. Benzo, man, the frequency, right? That's how you remember it. All right. So the these ones are for the neuromuscular anti-epileptics. Um, Whenever you see like the farm, right? You will have to know all mechanism of action and then a side effect, all everything, of course. But many drugs are, for same conditions, you can use many drugs. But one thing you have to know when to use that the particular drug is when if that is a drug of choice. Drug of choice, you have to know this drug. Okay, for certain conditions, for instance, like the butyl 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 means that the absent seizure, right? So, what do you use in butyl? The what is it? Uh, Epoxide or something like that. I forgot the name. One of the epilepsy drugs that epoxy is not in here. Okay, so that's the thing that you need to use. Okay, so that's the drug of choice. Like carbamazepine, for instance, if you have the trigeminal neuralgia, then it's very sensitive. The overreacting, hypersensitive, hyperreacting the symptoms in terms of the face. Okay, so trigeminal. So trigeminal lobe is overreacting. Okay, the carbamazepine is like drug of choice. You need to know that drug of choice. Okay, so uh, so in that case, the you need to know like what kind of the drug you use. Okay. So another thing you need to know is here, phenytoin. Whenever phenytoin occurs, they will ask you about the elimination order. This is a zero order. Zero order drugs that the similar process as the phenytoin is a PEA, phenytoin, ethanol, and the A, the aspirin. Okay, those three, zero order elimination. Doesn't matter how much you drink, or how much you consume. It's just time. Only one time, like 1 minute, how many it will be eliminated. Okay, so phenytoin is one of them. All right. So, all right. So, also another thing you need to know is the myasthenitis gravis, edroponium is for test for diagnosis, and then pyridostigmine is for the treat. Okay, so something you need to know. All right. And the reason that this is for treatment is myasthenic gravis is a CNS problem, right? And this one is because of the BBB, all right? All right, this one myasthenic gravis again, another association, big association here is a thymoma. Edroponium test, treatment pyridostigmine. Okay, and then it's because it's thymoma, thymectomy. Okay, and because it's autoimmune, so you use the steroid too, right? So also another thing is that you can do is like a passive because this is kind of if it's not working, then you use IVIG. IVIG means like it's a passive immunity, passive immunity. So basically, if you are hungry, then you give the food only. If you are thirsty, you give the water. Instead of active immunity is like giving you how to dig the water well, how to make food. That's active immunity. Passive immunity is you give the food. Okay. All right. Lamborghini and then myasthenia gravis. So myasthenia gravis is the post. I mean it's a here. Myasthenia gravis is the post-synaptic nicotinic the here post-synaptic acetylcholine receptors. So synapse here, and then post-synaptic acetylcholine receptor. So this is antibodies against this one. Antibody against this one. So basically, this one is the receptor is acetylcholine receptor is not working. So that's why even if acetylcholine is there, it's not working. Okay. So the way you treat is acetylcholine esterase inhibitor. What does esterase inhibitor mean? This is acetylcholine esterase inhibitor. Esterase means that it will break down the acetylcholine. Right? Esterase means the breaking down. So acetylcholine breaking down inhibitor. So not breaking down. Acetylcholine remains in the synaptic cleft. So more acetylcholine will be there. Okay, so that's how you treat. So pyridostigmine is one of them. All right. Lamborghini is not in the postsynaptic the acetylcholine receptor problem. It is a presynaptic calcium channel problem. Calcium channel, when the calcium channel is a calcium channel here, that calcium channel is activated, then that will make the vesicles to release. Inside of the vesicle, there's a acetylcholine. In terms of if there's a like neuromuscular junction, the inside of the vesicle, acetylcholine is there. But calcium channel is blocked, so the calcium is not going to be initiating the action potential to release the vesicle. Vesicle is not released because of the acetylcholine. I mean the calcium channel is not there, so no action potential occurs, and then no vesicle like touching this line here. touching the membrane, and then cannot be released from the cell, from the presynaptic neuron. Okay, so that's what this means, right? Now, always like the associated disease is because it's autoimmune. Autoimmune is like this associated Hashimoto thyroiditis, and then SLE, and then rheumatoid arthritis, all autoimmune. I think this one is also some associated, yes, same thing, right? So associated symptoms are all basically autoimmune, autoimmune, always kind of associated. It's no surprise. Okay. Botulism is basically all you need to know here is that uh, infant is like fluffy baby syndrome. Okay. The also the canned food, where is canned food right there? Canned food, and then raw honey for the infant. Okay. Because infant, I think the Sunny mentioned about this. Infant is low in the immune systems, and gut bacteria cannot kill those the botulism toxin. So that's why normally if we are the old enough, that's not problem. Over 1 year, over 2 years old, it's no problem. But if you are under 2 years, your gut bacteria is not forming yet. So that's the problem. Okay, fluffy baby syndrome. All right. I mean, for any of this kind of any of diseases that like something to do with the muscles, always airway first. That's just a basically common thing, common sense. Okay, always because what kills you, what kills the patient is the muscle. Muscle is not functioning. Then what's going to happen? You cannot breathe. That's the problem. That will kill you, right? So always airway first. ABC. You know the ABC, right? Airway, breathing, the circulation, right? So A is first, okay? All right. And then there's some the cranial lobes, and I kind of skip this one because you already know these ones. And then just know that down and out, and then also like the location posterior pica, right? Posterior communicating artery. Posterior communicating is basically here, this thing, okay? So what is it? Basilar, and then the like this the artery, vertebral artery, and then basilar artery, right? And then the posterior communicating artery, right? And then the MCA goes here, MCA, and then here, and then anterior communicating artery here, right? So you need to know this thing, okay? And then there's a ICA here, anterior communicating artery, sorry. So, you need to know inside out by heart for the circle Willis. That's just a very, very important thing, okay? So they assume you already know this when you learn this in the med one, okay? So you have to know this. All right. And also another thing is that this is a very, very important thing. Cranial right? Has a two parts. You know that? So there's a motor part, and then there's a parasympathetic part. Parasympathetic part is kind of circling around, like the kind of like wrapping around the motor part. Okay. So what's going to happen if it's the compressing something? Okay, if it's a compressing, what will be? This is a parasympathetic. If it's something is compressing, what's going to happen? Which one will affect first? It will be parasympathetic or the motor. If it's compressing from outside, which will be affected first? More affected. You can or unmute and say, or write down in the chat. Which will be affected first? Parasympathetic. I mean, if it, in the compressing, if it's compressing, something is compressing, some tumor or something, whatever. What do you think? if it's compressing from, this is, see this outside? Is outside is the parasympathetic, okay? Inside is the motor neurons. Because CNS is a motor neuron, right? So CNS is like the oculomotor neuron, right? And then the parasympathetic, CNS3 is basically kind of two part. One is a parasympathetic part, and then one is the motor part. Parasympathetic, they go parallel, but the parasympathetic is kind of wrapping on the outside. It's more, if you draw it like here, it's the motor part, and then parasympathetic goes like this, parasympathetic part. Okay, so if you are compressing from outside, something is compressing, then which will be affected more? Because you are compressing from outside, so then yes, parasympathetic will be affected more. That's the compressing. You have to know this, the difference between, if it's a compressing, that's parasympathetic the first. Okay, but whereas if you are ischemic, then what's going to happen is that if it's ischemic, then what happens is that the blood supply is a blood vessel here. Blood goes here. If it's a lack of blood, ischemic means a lack of blood, right? Lack of oxygen, but lack of oxygen, and blood carries the oxygen. So if it's a lack of blood, then this blood vessel carries the oxygen, but now it's only this big. So the parasympathetic here, and then the motor here. So what happens is normally this is like supplying all the way to the inside, right? But now only little bit of blood coming in, so only supplying this much. Then no, nothing in here. So which will be affected first? Remember the cardiomyome. So this is like the heart, right? And then coronary artery goes in the outside, right? It will supply the blood vessels here, right? So there are like three layers: epithelium, epicardium, and then myocardium, and the endocardium. Endocardium is very inside. So if you if we are lack of supplying blood, then which part will be the ischemic? Then which part will be dying first? You are supplying here, okay, but you cannot supply here. You cannot supply at the very end. So endothelium will, inside of the layer of the heart, will be dead first. Okay, so the cardiomyome, it's like this part will be dead. This dead here. No, this will be the typical MI. No such thing as this part. That never happened. Okay, so parasympathetic will be the affected first. Then it's going to be, so this is very important. This will be in the exam, and I think this is very fair question. That if you experience some parasympathetic the symptoms, so that means what? That means something is compressing. If there's something that motor part, your the oculomotor is not functioning, but parasympathetic is still okay, that means something ischemic problems. Okay, so you have to distinguish this two very, very clearly. So this I'll circle here. This is very, very important. Okay, so this will be very, very important. You have to know this one very, very clearly. This is important not only in step 1, step 2 is this is also in the exam. Okay, very, very important. Okay, number 6, I mean the 4, all you need to know, 4 palsy. 4 palsy. 4 palsy, you need to know this thing. Where is this thing here? You need to know head tilt to opposite side, and then when looking down, so stairs, down, stair, problem. Okay. Also, road reading. It's because it's a diplopia, so you cannot read your lines will be like a, the line is supposed to be like this, right? Your line will be like the one eye like this, the other eye like this. So lines will be like this. You cannot read. So it's a reading problem. And then you have the walking downstairs problem. Okay, so those two things are important. Okay. This is very common condition, very, very common. Okay. Another condition, another thing you need to know is, I told you about the lack of rule of four, right? It's the midbrain, equals midbrain. 1, 2, 3, 4. 1, 2, 3, 4, right? The midbrain, right? All right. Also, another thing is the 6, not the 4. Okay. 6 is a cavernous sinus, right? Cavernous sinus. The 3, 4, 3, 4, B1, B2, and 6. 6 here. So this is like the internal carotid artery, Okay. So if there is the pressure, the intracranial pressure is high, then this will be like this will be damaged. So no, sorry. So this will be like a kind of pressure is high. That means like this may rupture, something like that, right? What will be affected first? This one is far away. This is in the middle. So this is just next to the internal carotid artery. So when there's something rupture, hemorrhagic condition happens due to the internal carotid artery, 6 is first affected. So when you see the 6 is like obtuscens lobe, okay? But the correct pronunciation is obtuscens, but if you are unsure, oh, was it 6 or 4, right? So if you're unsure about this, I know that one of the 6 is cranial 6 is like doing the abduction, okay? So then you like pronounce it as obtuscens, abductions instead of obtuscens, abductions, abduct, right? Abducts. You pronounce it as the abduction. So then you will see the yeah, those are due to abduction. Okay. So that's for the cranial the 6, and then cavernous sinus. This is your cavernous sinus, right? Another thing is that the vagus nerve is there is like the recurrence pharyngeal lobe, recurrence laryngeal lobe for dysphagia voice. Okay, and this one probably not because they are not really very, very heavy in anatomy in med 3, but it might be appear for the anatomy part, so that the this will be just easy for you if it's easy point if you remember this, that circles like a kind of the circles in the aorta, okay, it's like a circle here, right? Circle here. So it's just a circle down and then goes back. So that's why it's called recurrent laryngeal nerve. Okay. So just the course way, just this course. Remember this course. Okay. Where are we now? Okay. All right. And then complete let me see. Complete optic nerve region present. Epidural blindness. Yeah, optic nerve is this is kind of opposite. I mean, this is obvious, right? Optic nerve is basically cranial nerve too. Your vision. If it's the block, then you cannot see, right? So just as obvious, right? And the usually the bitemporal hemianopsia, right? Bitemporal hemianopsia is basically you don't see temporal part, right? Bitemporal hemianopsia. You don't see this part. though you cannot see this part. That's bitemporal hemianopsia. But opposite things will happen in here because this is like the optic chiasm, right? This is optic chiasm, and then there's like the nerve, optic nerve goes like this, right? And then so this will see the medial part of the medial part of the pigeon, and then this will see the medial part, right? And then because of that's what the you see the medial part in here, medial part in here, and then the lateral part in here, lateral part here. So it goes here. So it will see this way, and then it will see this way, right? So I mean this way. Then this will be the going. You see this direction, this directions. Okay. So this will be lateral part, and then this will be medial part. So if you have some, this is kind of, this is not very, very common condition, but if you have a perichiasm, like a blocking. So what this is means is that this is supposed to be like this, right? This is the optic chiasm, and then if you have some compression here and then here at the same time, which will rarely happen. Okay, so usually this one is like a very, very stretching. It's usually unilateral. If it's bilateral, this here and here together rarely happens. But if it's a unilateral, then it will be like this. Okay, one side is okay, the other side is the block. Only I'm sorry, not this way, the opposite. So one side is okay. So one side is okay, but the other side only medial part. Okay, so this is when the optic chiasm is okay, it's okay, but this side is problem. Then this will have okay, something that it's kind of obvious thing, not very high. All right. The although that the eye thing will never go away. I think it's always a big topic for the neurology, but the because you already covered this lot of portion in the during the the semester, so that's why it's not very high in math 3. Okay, so it doesn't mean that the eye is not important. Another thing important here is web and learning. This will be this will appear for sure in the ICM. Okay, so but this is a very, very obvious and not so difficult test you don't want to miss. Basically, you have to know this conductive hearing loss. Conductive hearing loss means something ear, external ear, and then internal ear, right? Here, that is basically, and then there's like a middle ear, right? So here is a conductive hearing loss. Inside, sensory neural hearing loss. That's what you need to know. Okay, inside like inside the cochlear part. That's the sensory neural hearing loss, and then middle ear or outside external ear or middle ear is going to be the conductive hearing loss. Conductive hearing loss can be something like a blocking. Think about like blocking some wax, ear wax. It's blocking the ear canal, external ear canal. Obviously that's the conductive hearing loss. But the if there's some cochlear nerve, some damages, sensory neural hearing loss. Okay, so that's you need to know where the location is, which one you're talking about. Okay, inner ear, sensory, and then external or middle, conductive. Okay. Now the test goes like this. You first, you first put the vibration fork in the middle of the like this forehead. Okay. Normally it's same. Normally same, but if there's a this is louder. This is louder. This side is louder. What does that mean? This is louder. If it's the conductive hearing loss, then this is if it's a problem, then louder. If it's a sensory neural hearing loss, then this will be how softer. Okay, something you need to know this one. Okay, so I will write in here. Conductive hearing loss, louder. Sensory neural hearing loss, softer. Okay, so for instance, if we have a the put in here, and then this was louder. What does that mean? So right side, left side. Right side, the conductive hearing loss. That's one possibility, right? So also this is louder, and then also another possibility. That's one possibility. Another possibility is that this is louder. That means that this is weaker, right? So that means louder, then weaker, right? Softer, right? So in other words, this is right side of conductive hearing loss or left side the sensory neural hearing loss. Because we don't know whether it's because the left side is weaker or right side is louder. We don't know, right? We don't know which is louder or we don't know which is because it's just relevant, right? So we are just comparing the is it louder this side or left louder this side, So this one is only two possibilities, right? So the way you distinguish this is the Linear test. Linear test is normally AC is louder than BC. What AC is louder than BC means that when you the do this like at the forehead, now you the take out and then put it into the ear. Do you still hear? If you still hear, and then where do you still hear? That's what that means. So if it's the one side is louder, you have to do twice. You have to do the right side and then you left side. Can you still hear? Okay. Can you still hear? Then if you still hear, if you say still hear, what does that mean? If you still hear, the AC is greater than BC. Bone conduction, so it's weaker than the BC means that weaker than AC means that you can so in air conduction is louder, right? So it's lasting longer, right? So in that case, so what does that if this is the case, what does that mean? Is so the now you have a in the from the Winnie test, I mean from the Weber test, you concluded either you have a right side of conductive hearing loss or left side of sensory neural hearing loss. But normally the normally air condition supposed to be lasting longer than the bone conduction. But in the left side, I mean right side, you see air condition lasts longer than the big bone conduction. What does that mean? So meaning that this part is normal, right? So this the right side is normal. Right side is normal simply means that you have this thing. Because the right side is if it's right side is a problem, then you will not see this one. Right side has no problem. Problem is in the left side. Okay, but if it's so the let me if that so in other words, if that's the air condition was louder than bone conduction, then your conclusion is the left side sensory neural hearing loss. On the other hand, if the AC was greater than BC in this side, I mean, no, sorry, AC was less than BC in this side. Let me just erase this thing. Yeah. AC was less than the BC. What does that mean? Then that means problem is it was not supposed to happen, right? So in other words, right side is a problem, right? If that's the case, then right side of conductive hearing loss. Okay, so this is a just basically you remember one side and the other one is the other one. Okay, so remember this, and then the other one is just the other one. You just think about the other way. Okay, so remember you can take the screenshot of this, but this is a very common topic on the ICM quiz as well as the real cast. Okay, so this will be on the exam for sure, ICM, but this may appear in the real cast too. Okay, not in the ICM quiz, real cast too. So take a screenshot of this, and then this is the summary table. Instead of memorizing this, understanding this, you will never forget. Okay, all right. So cause of, I told you about the like the basically what earwax or because it's a medial or middle ear or external ear. So external ear, middle ear is maybe some infections, or that's media and obstructing mass. That's all conductive things. Okay. All right. And also another big thing, I mean, not big thing, but another thing, small thing, say, uh, you need to know is high frequency. As you get older, you cannot hear very well, right? See, my mom has like a hearing loss, right? So she has it's called presbycusis, 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 okay? Presbycusis, basically old age hearing loss, okay? So old age hearing loss start with high frequency. So let me just tell you one story, real story, which is kind of funny, but not so funny for old people. So what happened is young people can hear high frequency, but old people cannot hear high frequency. So, in the high school or in the like middle school or even elementary school, they can hear high frequency because they are young, but the professors or the teachers cannot hear high frequency, right? So what they do is that they download the high frequency ringtones, so they are not supposed to communicate during the class, right? So they use download the high frequency ringtones, so they can still text during the class. But the teacher cannot detect that high frequency because you can hear, the kids can hear, but the teachers cannot hear. Professor cannot hear high frequency. Okay, so that's what the the situation was. Okay. Another okay. Another thing is that vestibular system. Okay. Here you remember this thing. So there are like basically three things. Vestibular means kind of the proprioception thing. Okay. So three things: semicircular canal, and then sacral, and then ventricle. Ventricle. Okay. So semicircular canal is basically three things. One, two, three. One, two, three. Okay. So and then the article is for horizontal, and then secure is vertical. So sabbatical, I like sabbatical is a vertical. I don't know it's how how you can memorize it, but the sabbatical is I remember, I just pronounced it as a sabbatical. Sabbatical, sabbatical, sabbatical. Sabbatical is a vertical. Okay, so just know that. And then also, so semicircular canal is basically three, one, two, and then three. So like three-dimensional thing. Okay, so there is a like the fluid build up here. Fluid goes here, 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 and then it's depending on the fluid amount where they can detect the like a proprioception. Where am I? So that's a very very delicate system. Very like highly kind of delicate system, complicated. Not so complicated, but it's a very useful system to detect where you are, right? So motion sense. Okay. Now the very very popular topic is a BPPS. BPP, I mean BPPB. Benign paroxysmal positional vertigo. Very 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 popular symptoms in many many the cases in there. Like this is a very benign, like almost probably like this is like a very popular condition. So a lot of people have this. Like old, if you get even young people have it. So many people have it. Like, I don't know the percentages because it's benign, so it's not very popular. I mean, very like serious condition. So I don't really know the statistics, but it's probably maybe more than half of the population have this. Okay, so at some point in time, so the question comes in like this. Okay, what's the problem? Problem was there is some kind of fluid like circling around all the time. So it just when you move tilt hand, then this will be just tilting the side, and then the fluid circling around, and then fluid level, depending on the fluid level, it detects body detect the position. Okay, so problem is there's some the blockages in the fluid. Okay, so there's some kind of stuck in the something stuck in there. Okay, so that's the problem. So there's a little bit of a thing, kind of little kind of not because of only fluid, but supposed to have some kind of some particles supposed to have the moving around depending on your position. But if the particle is stuck there, that's the problem. Okay, so the what's important is this thing. This what happened here? Oh, my pen was my pen was out of battery. Okay, so anyway, so I can write in here. So problem is this thing. Dick Holpike maneuver or Appley maneuver. Those two are the maneuvers that resolve this within like 1 minute. I mean within like 2 minutes. You can just do this maneuver. Very easy. You can just YouTube this the just type in the Holpike maneuver or the Appley maneuver. Very easy to maneuver. You can just resolve the issue very quickly. Okay. It will come back, but so you can just resolve the issue very quickly. So uh, something you must know. Okay, another important disease is called Meniere's disease. Also, can I just take 1 minute break? Okay, just a minute. Okay, let me just take a 1 minute break. I'll come back. All right. Sorry about that. All right. So Meniere's disease is it's a kind of the what you need to know is like it's a the endolymph. Endolymph is some kind of lymph kind of fluid that is supposed to be the circulating around the cochlea and then the vestibular systems, and then that lymph is too much or the draining problems. Okay, that's what happens in the Meniere's disease. And then you need to know what you need to know is um, these things in here. It's um, the presentation. It's usually like kind of hours. Okay, and then usually happens in the unilateral, and then also the tinnitus, and then sensory neural hearing loss. Basically, all you need, all things are the concerning about the ear. Okay, and uh, the also it occurs in the nystagmus. Okay, so the nystagmus. So it's this thing. So here, for instance, why let me explain why nystagmus happens. Okay, so suppose you're here, then you are turned to the this side. Okay, and then suppose this eye is a problem. Okay, that's problem. Turn to this eye. I mean this side. You okay? Can you turn to the left? Okay, and then this will go like this, right? But this eye doesn't move, right? So what's going to happen is that it will slowly move, right? Slowly moving this side, but whereas this one fast move, right? So then body try to, oh, something wrong. I have to fix it. So then this will move, this one will move, oh, I have to fix it quickly. So this will move quickly to this side. Okay, this side will move, correct, correct the location of the eye to the left side very quickly. So then that will beat. So that will beat, beating. It's called beating. Beating means fast move. It's a meaning, it's a corrected, correction, say. So this is a nystagmus, okay? So that's the mechanism behind the nystagmus. Nystagmus happens many ways, but that's the mechanism. So direction of the correction is the nystagmus, okay? Let me see. So this one I'll just skip, and then here. So this is like the cancers. The basically all you need to know is this like general term. Okay, so children, this tentorium is like a kind of tentorium here, which separate the cerebellum to the main part of the brain, right? So before tentorium, adult, above tentorium, and then below tentorium, kids. Okay, so that's the general term. Of course, there are many exceptions. Okay, all right. So medulloblastoma is for children, and then this one all you need to know is let me just circle highlight what you need to know. Okay, it's a pomis of the cerebellum, and then infratentorial. That's a usual location. Okay, and then let me see, homorite. This one is important. Homorite pseudo rosette. So this is a homorite pseudo rosette. This thing is homorite pseudo rosette here, like this. This is rosette. Basically, looks similar to this one, right? Pseudo rosette. Okay, homorite pseudo rosette, and then small round blue anaplastic cells with minimal cytoplasm. Small, because if you look at this, small cells in the small cells in here, right? Small cells with a minimal cytoplasm. It's a cells has a very big the NC ratio. NC is big, so cytoplasm is very small, right? This is almost no cytoplasm here. Small cells. Okay, so that's what the pseudo rosette means. Okay, so this kind of I told you this kind of description was really it doesn't ring the bell to me. It doesn't. Okay, oh yeah, I see the Sujo rosette, I see the like small round blue cells, I don't really see. But that's what it is description of the this histological the pictures. So you need to know, you have to kind of familiar with these terms, like former right pseudo rosette, which is like small round blue anaplastic cells with minimal cytoplasm, and then forms the like the kind of rosette like this. Okay, so that's the things that you need to know. And then this is for kids. And then the medulloblastoma is normally it's the infratentorial, so it's kind of in the cerebellum. Okay, and then pilocytic astrocytoma. Okay, so in the name, it's kind of easy to understand. Astrocyte. The kids has like some kind of the kids has astro. Some kind of the space things like this, right? So basically, astrocyte is actually the although the name is astro, but it's actually some glial cells that is in the CNS, okay, in the brain. That's the glial cells, and the name of this is it's astro is I think it's due to it's a kind of star-like shape. Okay, so that's why it's the astrocyte. So anyway, so this is the astrocyte tumor, and then neuroectoderm, and then also whenever there's a glial cell, GFAP, glial fibrillary the acidic protein. GFAP means astrocyte. I mean, the GFAP means glial cell tumor. Uh, glial cells are high. Okay, so it's also in the infratentorial, so cerebellum, and kind of the I don't really see kind of rosenthal fiber, hair-like projection. I have no idea where can I find this other picture. It doesn't look like a hair-like projection to me. But the something that you need to know these terms. Okay, I'm very being honest that I don't see this kind of features in this histogram, histology pictures. Okay, but you have to know these terms. That's what because that's what will appear in the exam. Okay, especially the for Med 3 and Med 4, the professors are very pro, very favorable to, I mean, not favorable, say, they love to use these terminologies, okay? So you have to know these terminologies, all right? Craniopharyngioma. This one is something you are familiar with because you learned this in the first year, right? So Rasket pouchy and surface ectoderm and the supracellular region. Supracellular is where the pituitary gland sits, right? So you are familiar with this. Now you're okay with them, okay? And then another thing is that the perivascular pseudo-rosette seen in ependymoma. Ependymoma is a ependymal is a bit there, but in the first ventricle, ependymal cells is that is concentrated in the first ventricle that makes the CSF, right? So ependymal cells. Okay, so that's what you need to know. And then first ventricle, and the also the yeah. And if we select two much tumor in there, first ventricle is right there. So first ventricle is right here, and oh yeah, right here. And then if it's a tumor, it will block, right? So if you block here, then what's going to happen? It will just pressure build up, and then because of this blockage, you have the CSF backed up in the like ventricles, right? So it's called obstructive hydrocephalus, right? Because of this, the block in fourth ventricle. Okay, this is what you need to know, right? Obstructive hydrocephalus. They will ask you whether this is a obstructive, the hydrocephalus, obstructive or non-obstructive. Obstructive means the block. Obstructive means block. Non-obstructive, non-obstructive means the drain, no drain. Okay, that's the non-obstructive, the hydrocephalus, which is, this means that there's no drain. Okay, all right. uh, Now you really need to know this picture very, very well. Just know this. Having just knowing just this picture will make you maybe not very, very high, but at least one questions in the CAS and then in the STEP exam, especially in the pediatric rotation shelf. You will have to know this picture. Very, very popular for pediatric cases. Okay, so kaput is very popular, and those are all very popular. There are more, but so these are all popular things. So know this picture, right? Know this picture very, very. Just it's easy point. If you know this picture, you can just start without even thinking. Okay, all right, and the global now is a adult. Adult, it's a glioblastoma multiforme, GBM. That's the most common. Okay, and then basically this is a adult version of the astrocytoma. Okay, so one thing you need to know here is like a butterfly. It's like a butterfly. This is a thing that the I'm okay. So I see butterflies, right? Okay, this one, I'm honestly I know, I can see the butterfly shape here. Okay, so so you, because it's also astrocytoma, and you have like a glial cell, so you will see the GFAP glial cell. Yeah, you will see this one positive. Okay, although I'm not sure why they don't mention it here, but you should have this marker. Okay, because it's a glial cell, right? And then let me see, vestibular schwannoma. This one is important because of this one, acoustic neuroma, right? So the what's important, really important thing is this thing, neurofibromatosis type 2, neurofibromatosis type 2. Okay, this is like a tools, all tools, right? So bilateral, the vestibular schwannoma, and it's also Eurofibrosis. Yes, NF2 is a U. I think it doesn't have the cafe region, I think, but the and it happens in the cerebello pontine angle, CPA, and the so S100 positive, and then there's a two bunch of bilateral something. Okay, bilateral. I think four, three or four things. You need to know this one. Okay, it's in the first aid. You need to know this one. This is very, very important one. Okay, important page, and then you need to know this. Okay, so and again this one, I come back with this one. Oligodendroglioma. So this one you need to know, like chicken wire. I think this one represent the chicken wire. I have no idea why this is look chicken wire, and then I have no idea why this is the kind of the fried egg. Maybe this one. I have no idea. Okay, so this one maybe I'm not sure. Okay, so this is a fried egg appearance, and then the chicken wire. That's what they say. Okay, and then the frontal lobe is in the frontal lobe. Okay, oligodendroma. So fried egg, and then also because it's in the frontal lobe, executive functions and personality. So that's the key thing. Frontal lobe, personality changes. So do you know frontotemporal the dementia? This is one of the manifestations. If it happens in the due to I mean one of the cause, this will cause a frontotemporal dementia. That's one of the common cause of the frontotemporal dementia. Okay, so you need to know that. All right. Meningioma. I will tell you the important thing. Samoma bodies. What does samoma bodies mean? It's kind of this thing. Okay, onion. Okay, whenever you see onion thing, onion hyperplastic. What does that mean? Hyperplastic means that the many plastic, meaning that the like the how do you call that? Like instead of hypertrophic, hyperplastic means the new cells will be generated. New cells, new cells, new cells. So this is onion means new layer appears. Then another new layer, another new layer, another new layer. That will make one layer appears. Then another layer over it, another layer, another layer, another layer, another layer. So that's why it's called onion shape. Okay, so this one occurs whenever there is a hyperplastic. Okay, hyperplastic means that like new layers over and over, new layers building up, building up, building up. Okay, so uh, so this is like something you need to know. And then one important thing is that this is a negative meningioma, negative for the GFAB. It's kind of making sense. Meningioma, meninges, meninges, meninges is basically dura, arachnoid, and then pia mater. Only this thing, right? So are these something supporting the neurons in the body? I mean, in the brain? No, they are not. They are just covering, because only covering, right? So it's not the supporting cells, not supporting cells. Not supporting cells means that not glial cells. Glial cells means supporting cells. Not glial cells, then no GFAP. Okay? So don't try to memorize that, oh, this is negative for GFAP, but understand why this is the no for negative for GFAP. Because this is not supporting cell. This is meningioma is a meninge is not the supporting cells. It's just a covering. Okay? So that's the important thing. Okay? So this one is important. Okay? All right. And another thing is that the samoma bodies. Okay? So samoma bodies is kind of this world, the shape thing, right? This is eosinophilic walls. Okay, so there are 4 conditions that has a samoma bodies. You have to know this. This is important. Okay, 1, 2, 3, 4. Meningioma here, meningioma, and then mesothelioma, mesothelioma, thelioma, which is a kind of the long kind of covering, right? Long the thing. And then the another thing is that the papillary. Just a minute. Just hold on a second. Let me just let me just quit. I mean, just cheat a little bit, because I don't want to give you wrong information. It just means some about this. Some this, which is a microphone like this. Okay, maybe here. Just a minute. Oh yeah, papillary. Yeah. Okay. Where, oh, where is the thing? Here. Okay. So papillary, thyroid, cancer, and serous, or whatever you use, the serous, the carcinoma of ovary. Those four things, you need to know these things, four things. That has the sum of bodies. Sum of bodies is walled structure, like this one. This is a walled structure, like this one. So walled structure, right? So walling, okay? Those are sum of bodies, okay? Okay, um, let me see. This one, you will probably need to know, but you know this because it's time limit, so I'll just skip this one. Okay, right? Ischemic cerebral accident. Okay, so what you need to know is this one. Most common is MCA, and then another thing is that when basically this is a kind of equal stroke. Okay, when the stroke comes in, the first thing is a non-con CT. That's the first thing you have to do. Non-con-CT, very, very first thing. Because you have to distinguish between the hemorrhagic and then ischemic. Because hemorrhagic and ischemic are two different things. You have to treat differently. So that's why the first thing you do is the non-con-CT first. Okay. No stroke is non-con-CT, very first thing. Okay. So you need to know that. Okay. Then depending on that, you have to kind of treat. And this one is a very, 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 very important table, along with the MI, the timeline. Okay, so very, very important. First 1 to 3 days, neutrophil stage. After that, macrophage stage. And then after that, it's a reactive gliosis. And then after that, it's kind of autoimmune thing. Okay, so this timeline is very, very important. Okay, it will come out in the exam. And then another thing is that usually this is in the MI case, this is a coagulative necrosis. No, it's basically it's coagulative necrosis ischemic. But the in brain, no coagulative necrosis. It will have a liquefactive necrosis. Okay, the reason is that because of the BBB. Okay, so if you want to know why BBB causes liquefaction necrosis, just look it up the internet. Okay, YouTube has like some very good explanations for it. Okay, all right. Now the MCA is the most common. Okay, so that's what you need to know. Right. So let me see. Lacuna infarct. Basically, what you need to know is chronic hypertension causes lacuna infarct. Okay. And then let me see, internal capsule, because of the internal capsule is like this, right? So what happens is this is like basically gateway. It's like a toll exchange. You can just toll gate, say toll gate. Think about toll gate, internal capsule, toll gate. So toll gate, you don't like incoming traffic, outgoing traffic, right? Incoming traffic, outgoing traffic don't mix. They incoming or out, right? Not mix. So you need to know this. Internal capsule, incoming or not outgoing, they don't mix together. It is going to be accident, right? So that's why it's going to be pure motor or pure sensory. Okay? So that's the most common. Very, very important. Internal capsule, in fact, there is a the pure motor or pure sensory because it's a toll gate. Internal capsule is a toll gate. So only incoming. Say what happens is if it's a problem here, that's the only incoming. If there's a problem here, or only outgoing. Okay. So that's what happens here. Okay. So that's why it's a mixed is a little bit kind of it's rare, but in this case, if it's more area, wider area, then it's mixed. Okay, that's something you need to know, right? That's Larkin syndrome. I told you about this, and then the secondary prevention. This yeah, this if you know this Monabash, If you know this, this is secondary prevention, means Monabesh. If you know what that is, you will learn during the class. But if you can the Google Monabesh, you will know what that is. Okay. Circle of Willis, I cannot emphasize more than more very important. Okay, of course, right? And epidural hemorrhages and consideration this one. Yeah, I think the although I have some the some about 30 some pages, I cannot cover all of them in this session, but it's oh, another important thing. This one I'll just circle the important pages. This one very important. Okay, so let me start channel.
Is it safe to assume that all the conditions you have in these slides are covered in Med 3 that we're going to possibly be tested
Yeah,
on?
you will see all of this. You will see all of this slide. The topics in the slide will be covered in the math.
Okay, so even
So
if you
you will
don't,
not, okay, let me tell you this. You will not, this is your final chance of the neuro. You don't learn neuro in Med 4.
okay,
So you learn in the neuro, Med 3, that's it. You don't learn any more neuro. Basically, your neuro session will cover everything in neuro. You are ready to solve the step 1 questions in neuro, which include all of this. Okay? So
yeah, no, cool. So even if, like I said, so even if you don't cover, you can't cover all the slides, um, just by you sharing the slides would be good as well because it
yeah, of course,
has
I
all the
will show
stuff
the,
on there. So I do
of course,
appreciate it.
yeah, of course, I will upload this annotated version. So so of course, I will show the slide, of course. But I will also upload this the recording in my YouTube channel. Okay. So just the I will upload the channel when I stop recording, and then I will download it and upload to my YouTube channel. So and then I will send the link in the chat. Okay. So just make sure that you like it and share. I mean, like it and subscribe to the channel. All right.
Will do, will do.
Yeah, okay. So the dementia, of course, the dementia is of course important. And let me see, migraine, headache, and those are all focal seizure. Yeah. Okay, so those are all very important things. I mean, the topics on here, it will be on your exam. It will be all of this will be covered in the Math 3. So there is no further neuro topics in the Math 4. That's it. Med 3, that's it. Okay? So make sure that you know this. From Med 1, I mean from Med 3 and Med 4, basically it's 1 year the set 1 year the classes that covers the final version of the subject. Okay? That's what I'm saying. Okay? All right. So I will stop here, and then because of time, and then I will be the TAing the med 3 and med 4 sessions as well. So I will be throughout the semester. I will do like med 1, 2, 3, 4 alternatively. All right. All
All
right.
right.
Thank you very
Thanks a
much.
lot, Kevin. No, we
Yep.
really
Thank you very
appreciate
much.
you.
Yeah, no problem. I will stop recording here and then I will upload the recording. All right.
All right. You have a
Thank
good
you.
night.